The content herein is for informational purposes only, not intended as medical advice, diagnosis, or treatment, and is not to be substituted for direct advice from your doctor.
Today's LymphCast program is proudly sponsored by VitaSupport MD, the makers of Vein Formula 1000 and Lymphatic Formula 1000. These MPFF-based nutraceuticals are backed by science and recommended by doctors specializing in venous and lymphatic disorders. Visit VitaSupportMD.com to learn more.
Welcome to LymphCast, the show that brings together doctors, other health professionals, and special guests to discuss lymphedema, venous disease, and other associated disorders, and what can be done if this is affecting your life. Now it's time to sit back, relax, as it's time to learn all about lymphedema, venous disease, and associated disorders on our show, LymphCast. Welcome to LymphCast. This is episode 2, wherein doctors and other mental health professionals will be coming in to educate you on lymphedema, venous disease, and other associated disorders. Let's go around the table and meet our panel from tonight. From New Jersey, physician surgeon, Dr. John A. Chuback. Greetings, Dr. Chuback. How are you?
Hi, Paul. I'm doing fine. Thank you.
Great to have you here. I'll come back to you in a moment. From Santa Monica, California, Dr. Emily Iker. Good evening, Dr. Iker. How are you?
Good evening, everybody. Thank you. I wish you all well. And it's in Santa Monica, it's 2 p.m. now, and we have beautiful day today.
All right. A beautiful day every day. At least we're still together, so that's what makes it good in many ways. And also from Scottsdale, Arizona, Dr. Monika Gloviczki. Greetings, Dr. Gloviczki. How are you?
Good. Thank you very much. Nice to see you all and to be again a part of this podcast.
All right. Glad to have you with us. Let's circle back to Dr. Chuback. I have you kick it off and take it where you'd like to go this evening.
Well, this evening we were hoping to have a couple of other podcast members for their formal introductions to the show. But again, as busy clinicians with lots happening in their lives, unfortunately, some things came up at the last moment and they were not able to make today's show. So we are going to play it by ear a little bit, but we have so much to talk about and so much to share. So in our discussion just before coming on the air, Dr. Iker was mentioning a very common scenario, and I think that could be a kickoff to a nice conversation that we as physicians and clinicians in the area of venous and lymphatic disorders, where we see a lot of patients with swelling of all kinds, which, as you know, Paul, we refer to in medicine as edema. These edemas, as we touched on in our first program, are often misunderstood, misdiagnosed, and mistreated. So Dr. Iker was just sharing with us a quite extreme example, I think, in terms of the dosing of a medication that was provided to a patient inappropriately to begin with, and then a massive dose of the wrong medication on top of it. So Dr. Iker, why don't you share with our audience that clinical experience you recently had, and we can maybe discuss it further.
Right. I just saw a 62-year-old lovely patient, a woman with a lower body mismatched with upper body, lower body with enlargement in symmetrical distribution of both lower extremities. She was progressively getting larger, and her BMI is about 30, 31 now. And the doctors are telling her, you just have to lose your weight. And she's telling doctors, I don't eat much. And they said, come on, you just have to adhere to the diet, and it is all diet related. Well, when I examined this patient, I, on clinical presentation, detected a lower body enlargement in symmetrical distribution in proportion to the upper body, relatively small, skinny waist, and enlargement of the hips with saddlebacks, and enlargement of subcutaneous tissue around the knees, and tapering down to ankles with little cuffing. The feet are spared in these patients. Well, this is clinical presentation, a typical clinical presentation of very soft tissue consistency and symmetrical enlargement of lower extremities with lipedema. And lipedema is not lymphedema. It is an abnormal accumulation of subcutaneous tissue, and it is a fat disorder with loose connective tissue disorder, as it was already pointed out in standard of care in the United States of lipedema, which was put together by 21 physicians in charge of Dr. Karen Herbst was in charge of this meeting, and it took about a year to accumulate all the data and so. So again, this is a typical presentation of lipedema. And a lot of patients and a lot of physicians are not well versed about lipedema diagnosis, lipedema condition, lipedema symptoms. These patients don't eat much, and yet they are progressing in enlargement of the lower body. They can gain 5 pounds over the night because they had larger dinner and so on. Well, again, I saw this 62-year-old lovely woman who is having difficulty with ambulation because there is a friction between her thighs and legs, and the doctor, and to my amazement, a cardiologist put her on initially 40 milligrams of Lasix, which is a water pill, 1 time a day. And she didn't lose much weight. So he escalated to 2 times a day. So now she was on 40 milligrams of Lasix or furosemide 2 times a day. And again, initially she lost a little bit, but then it stagnated and she didn't progress to lose weight. So now she tells me for the past week, she is on 80 milligrams 2 times a day, which is a very high dosage of water pill. Well, in addition to that, she's taking a potassium supplement. And she said, I am not losing weight. So I'm afraid that the cardiologist, not knowing that lipedema is not going to respond to water pill, is going to double the dose again. So I would like to point out that again, lipedema is a chronic and progressive and debilitating disease in these women, and it is of genetic makeup. And if not diagnosed early, the lipedema will progress. And initially we see lower body with symmetrical distribution and enlargement. And if it progresses, it may involve the upper extremities as well, abdominal area and truncal area. And frequently you can see these women suffering greatly when they are just walking and doing shopping in the stores. They can hardly move. And this is not related to a dietary intake. And I have to point out that in the past, I had a patient from Midwest, and she came with the list and with the tears in her eyes. And she told me, you are the 9th doctor that I am seeing. And now you are finally diagnosing me because the last doctor told me that I should see a psychiatrist. And also she came with a statement that her primary physician wrote to the insurance. And it stated, let's face it, she is the one who is putting food into her mouth. And again, we have to listen to these patients, and we have to trust that these patients are not overeating. In addition to that, I've seen quite a few young women who had sudden progression around the puberty, onset of puberty, when they started to have bulimia, anorexia, directly related to this enlargement of the lower body without knowing what is happening to their body. There is a great influence of hormonal changes with hormonal influence to lipedema. Again, it is so important to diagnose these patients early and guide them with the treatment. And no, we don't have any pharmacological medication to fix this problem. We do have some help with the dietary influence, where we recommend for the patients not to have any sugar or reduce the sugar intake, which is quite difficult in today's diet. Eliminate gluten in a diet as well as dairy, and increase the exercise program. And going to exercise program, not that long ago, I was watching gymnastics, because way back when I used to do gymnastics in my homeland of Czechoslovakia. And when I see these little girls with symmetrical enlargement of lower extremities and hypermobility, which is also a point of lipedema contribution, with not only fat disorder, loose connective tissue disorder, but also hypermobility. And these gymnasts are standing straight with the knees are buckling backwards. That is also a component of lipedema. So again, the most important thing is to diagnose these patients early. And if we can start seeing that in a teenage group or even earlier, and guide them with the treatment, then they would not have to be in more advanced stages as stage 2 or stage 3 and so on.
It's that just backs up everything you folks have been saying from the beginning, and I've talked to Dr. Chuback over the last few years about it. It's often misdiagnosed because, in general, a lot of physicians don't know about this. And I want to turn it over to Dr. Gloviczki and get your reaction, and get Dr. Chuback's reaction. But before I do, Dr. Iker, you mentioned a physician had prescribed a water pill. In general, is that ever a good thing with somebody with lymphedema, or is that always bad? It just depends on the patient.
Well, it's always bad in the indication of lymphedema or lipedema. Doesn't make any sense to prescribe water pill for somebody who has the edema, except in the situation if this is edema of cardiac origin. All right, we agree that in this particular situation, this is a good indication, but not in lymphedema and not in lipedema. It doesn't do anything, as it was clearly demonstrated in the case of Emily's patient. So that's obvious for me. It's whatsoever water you could potentially lose in the case of lymphedema, it will attract in the second phase more water, and it will even increase the edema rather than decrease. So that's not the right prescription.
Okay, Dr. Iker, I'm guessing you agree with that, but I'm a non-medical professional. We have a lot of medical professionals watching and listening, and we'll have more down the road. We also have non-medical people like myself trying to find out what this is about, what they can do. What is the water pill in general supposed to do? Is that supposed to add water to the system, take water out? I don't even know. Maybe just tell us in general what that's supposed to do to begin with.
Well, it's supposed to reduce the fluid component in the tissue. But if the patient has only lipedema without any cardiac involvement, then water pill is not going to do anything.
Okay. Dr. Chuback, turn it over to you. You've heard quite a bit now, and a lot of it lines up with what you've been telling me the last couple of years. Are your thoughts on what Dr. Iker and Dr. Gloviczki have just said about that whole situation?
I think that they're all excellent comments, all completely appropriate, of course. But most importantly, it's what brings to mind again the purpose of our mission here, to educate. We're not here to criticize. We're certainly not here to criticize the patients who are afflicted by these disorders, and nor are we really here to criticize our colleagues who are physicians, because it's simply a matter of ignorance, and none of us can know what we don't know. Now, we can make the assumption that every physician should know everything, but none of us does. And unfortunately, one of my professors in cardiac surgery up at the University of Rochester used to teach that medicine is like other professions. When one knows how to use a hammer, the whole world looks like a nail. So it's not uncommon that the cardiologist who uses furosemide, also known as Lasix, a potent diuretic, who uses that very successfully daily in his practice or her practice to reduce edema in many of their patients, because they're dealing with various levels of congestive heart failure, as Dr. Gloviczki pointed out. And myself, as a cardiac surgeon, I used Lasix in my practice when I was doing open heart surgery very liberally. It was a routine part of the pharmacological kind of regimen that many cardiac patients are on. So because he's in that clinical milieu and seeing patients with that disorder, it's very easy for an individual who's seeing 30, 40, 50 patients a day, day after day, day after day, with edema that responds to Lasix. It's understandable how he or she could make the mistake of thinking, well, I'm not sure exactly what's wrong with this lady, but it's worked for everybody else. Maybe it will work for them too. So as I always try to remind myself that it is always easy to criticize when other physicians make mistakes, but if we put it in the rubric of a clinical context, it starts to make more sense. That doesn't make it right. It doesn't make it excusable. But at least for the general public who's listening, I don't want them to get the idea that we're here to bash physicians, number one, or that they're unsafe going to well-trained doctors in the United States. But we do see this mistake time and time again, and it's our mission in this program not only to educate patients, but to educate physicians and share with them our knowledge, and let patients know that if they have been put on diuretic, what we call water pill, again, to answer your question again, Paul, a medication used to reduce the overall body fluid and particularly water that is being trapped in the soft tissues, generally in the lower extremities. If they're being put on a water pill, they're not seeing dramatic effects, especially, they should be questioning that. The reason is because it is not an innocuous treatment. Besides being an ineffective treatment for lymphedema and lipedema, it is also not innocuous, and particularly can be deleterious or damaging to the kidneys, to the renal function, especially in high doses. So again, a patient who's being ramped up from 40 milligrams a day to 40 milligrams twice a day to 80 milligrams twice a day, that patient should also be very carefully monitored with blood work and laboratory indices to make sure that the BUN to creatinine ratio isn't getting out of whack. Typically, we look at something more than a 20-to-1 BUN to creatinine ratio as signs of significant hypovolemia or dehydration, and that can be very, very dangerous. So these these misdiagnoses and mistreatments, although well-intentioned, can have, in some cases, very, very serious consequences. In the worst case scenario, renal failure requiring hemodialysis and even transplantation. I have seen this in my practice over the years.
Today's LymphCast program is proudly sponsored by VitaSupport MD, the makers of Vein Formula 1000 and Lymphatic Formula 1000. These MPFF-based nutraceuticals are backed by science and recommended by doctors specializing in venous and lymphatic disorders. Visit VitaSupportMD.com to learn more.
You know, just to tag on to that, of course, we are never criticizing physicians. I know several physicians, not as many as the three of you obviously know, but I've never met one who doesn't try his or her best every single day to do everything they could possibly do for a patient. And I'm guessing in that situation with this water pill deal, increasing the dosage, whatever, at some point he would say, well, this isn't working. In fact, it might be getting worse. So I'll try something else. And I'm reminded of the time, you know, my background is education. I was a teacher and a school principal for a long time. And I took a few chemistry courses in college, you know, 150 years ago. And somebody down the street had a high school kid and they said, can you help my kid with his chemistry? I said, no, I probably can't. I can give it a shot, but it's been so long since I took it and I didn't major in it. I didn't minor in it. And he looked at me and goes, well, you were a teacher and a principal, weren't you? You're supposed to know this stuff. So, and I actually related it to a physician. I said, you take a physician who specializes in this area, they might not know as much about this second area. So it's probably universal from profession to profession, but nobody, I mean, everybody in your profession obviously tries to do the best they can with every patient every day. Right, Dr. Chuback?
Well, you would certainly hope so. I mean,
Yeah.
again, to talk in terms of absolutes, I have to admit that there are physicians, unfortunately, in the country who are unscrupulous and unethical and so forth, but they are tremendous outliers,
Right.
way beyond 3 standard deviations outside the mean of normal behavior, certainly. But on the other hand, there are many well-intentioned physicians who make mistakes. I mean, they're erroneous in their diagnosis and their therapy, despite having the best intentions. And that's why one of the things that I harp on again and again, not only in discussions like these, on panels with professionals, but in my practice, is that in today's day and age of contemporary medicine, we have so much knowledge. The knowledge is just so incredibly vast. It would be insane to think that any physician could know all of medicine. I mean, the subspecialization and super subspecialization now of medicine is so extreme that I think the lesson is that physicians should be very, very quick, in my opinion, to refer patients to specialists and subspecialists whenever something is getting really anywhere outside their main area of clinical interest and expertise. And that's the biggest mistake that I see. I see too many primary care doctors trying to be everything to everybody, which is noble in a sense, but I think that people have to reach out for help a lot more than they do, because we have so many fabulous specialists, subspecialists, and super subspecialists today. As physicians, we need to take advantage of that great knowledge base for the welfare of our patients.
I'm guessing most physicians, if not all, have a bevy of resources to go to. You know, for example, a family physician probably went to college with you, John, in medical school. So he knows you. He knows you went on to be a surgeon, but he can still call upon you in his moment of need. Like, I can't figure this out. Can you give her a look? Right? That happens all the time in your profession, right?
Yes, it does. And again, going back to the case that we're talking about, the case that Dr. Iker so beautifully presented for us, this is in a sense kind of a classic trap for a physician, because it's to the trained eye, Dr. Iker looks at that patient and immediately sees a patient with obvious lipedema. But to the untrained eye, or an eye trained for another disease, that physician sees edema and thinks diuretic. It's a copycat disease state. Not all swelling is the same. Not all quote unquote fat patients got fat the same way or are fat for the same reason, and so on and so forth. So we do have these clinical copycats, both physically that you can see and examine with your naked eye. And then of course it gets more complicated when we take into account diagnostic testing like ultrasound results, imaging results, X-ray, MRI, CAT scan, blood work analyses. There's lots of overlap in the field of medicine, which is why it is a very challenging and complicated and difficult profession. But when a physician isn't absolutely sure they know what they're dealing with, they should reach out for help. And certainly, if a physician makes a diagnosis and prescribes a treatment and finds that that treatment is failing, is not giving the anticipated result, then rather than doubling down and tripling down on that erroneous bet at the blackjack table of healthcare, he or she should reach out to someone else who may give another opinion and have another point of view, perspective, and a fresh set of eyes.
Now, I have the question to all of you. How many, let's put ourselves in the skin of the physician who is not knowledgeable. What specialist should she or he look for to have the second opinion on this particular patient? Because this is relatively new, and of course, you know,
I think it's a great question. I'm going to pass that over to Dr. Iker for her opinion first.
Well, we see patients from different physicians' specialties, and because I'm in Santa Monica near St. John's, former St. John's, now Providence Hospital, we see patients with, initially, I used to see patients after breast cancer. And after breast cancer, when they developed swelling, then we diagnosed them with lymphedema, which was directly related to the dissection of the lymphatic tissue or lymph nodes for the breast cancer surgery. And now we do have lymphedema center in Santa Monica, of course, but we have breast cancer center. We have melanoma center in St. John's Hospital. And we see also a lot of patients after surgical intervention for melanoma. And when melanoma starts anywhere in the body, melanoma is a skin cancer, which is quite malignant, and it may progress and invade the lymph system. And melanoma may appear in a foot or under the toenail and so on. But it's important to find out if the melanoma cancer cells migrated to the inguinal area, to the groin. And so the sampling of the lymph nodes is done. And the patient may develop lymphedema, a swelling in the leg, which then turns into a lymphedema. So we have a melanoma center. I see quite a few patients after prostate cancer or uterine cancer, and after surgical intervention of the pelvic cavity and or radiation treatments. So also I get patients from radiologists, oncologists, and interventional radiologists. And so whenever there is any swelling and they know about lymphedema center in Santa Monica, the patients are sent to us.
So let me jump in there. See, I think, Emily, your answer was excellent, but I think it was to a different question than Monika was posing. In fact, you were looking at it from the point of view. You were answering the question, what kind of physicians and what kind of doctors, et cetera, would refer patients to an expert like yourself? I think Monika's question was, and it's an excellent question, which was, for doctors who are seeing patients and they are confused, like this cardiologist who sees this lipedema patient in his office, and then he figures out this is not congestive heart failure, this is not typical cardiac edema, she's not responding to diuretics. Who could we suggest the primary care physicians, internal medicine physicians, et cetera, family practitioners who are seeing these patients, who should we tell them to refer to? In other words, you're a physical medicine and rehabilitation physician, but not every physical medicine and rehabilitation physician has nearly the expertise that you do in lipedema and lymphedema. I'm a cardiovascular surgeon. I can tell you that I think very few cardiovascular or vascular surgeons have expertise in lymphedema and certainly almost none in lipedema. So it's a conundrum. It's a clinical challenge because to this point, and I think this is Monika's point, and Monika can correct me if I'm wrong, to this point in 2022 in the United States of America, there has been very, very little development of a subspecialty that is specifically dedicated to the treatment and management of lymphedema and particularly lipedema. There's still so much ignorance in the medical community, and no particular group has singled themselves out as, we're the people that you should send all these patients to. So who should those primary care doctors refer their patients to? That's the question. Yeah. Now in Santa Monica, everybody knows you send them to Emily Iker.
Yes.
But what we're saying is on a broad scale in the United States, if you're in Paramus, New Jersey with me, if you don't know a specific individual, who does that cardiologist refer to? Is it a PM&R specialist? Is it a, I don't know who it is. That's the question for you.
Yeah, that's a question. And actually, you know, that's truly, I had a experience of somebody totally spoiled with the Mayo Clinic because, well, when you take the vascular center, the Gonda Vascular Center at the Mayo Clinic, actually the situation is pretty straightforward because you have all specialty included among the consultants of the center. So if somebody is treating a patient that doesn't see any response, is just going to the next door and showing the images of the patient and discussing the case. And that's the advantage of the multi-disciplinary clinics. But that's the rare situation. Normally you have the situation like you, John, like all the practitioner in the rehabilitation center, maybe obesity center, I don't know, because they logically, you know, if these patients are considered as obese, they might finish.
Especially the problem gets harder, and I'm going to tell you, Paul likes these sort of medical surgical jokes, but the situation gets harder when the physician seeing the patient doesn't even know what the diagnosis is. If you haven't made a diagnosis, then it's hard to say who to send that person to when you don't know what's wrong with them. So we used to joke in surgery by saying, this is the worst case of whatever this is that I've ever seen. You know, it's like, we don't know what it is, but this looks bad, you know? So when you're seeing the worst case of whatever it is that you've ever seen, who do I send this to? I don't even know what it's called. I don't know that it's lipedema. So now if there were a fat disorder specialty residency, fat disorder specialty fellowship, that there was the kind of lipologist, that's a well-known field, then the doctor would say, let me send everybody who's fat of any sort to the lipologist. But as far as I know, there is no lipologist.
No,
At this.
no.
It's a good idea, though.
But maybe we should create one.
In America, they would have plenty of patients, for
Yes,
sure.
Unfortunately. Yeah.
So, Emily, any follow-up thoughts on that? How you would suggest the primary care doctor proceed in finding someone in what field, what specialty to refer these patients to for care? Because people like yourself are so rare.
Well, this is such an incredible question from Dr. Gloviczki. It's true, we do not have specialty. We do not have residency or fellowship in lymphology yet. And I hope that in the future, we will have lymphatic disorder residency or of fellowship, where the new doctors will learn a little bit more about this disorder of lymphatic problems. Now, as Dr. Gloviczki pointed out, Mayo Clinic has lymphedema subspecialty or center. And now big centers are opening up more subspecialty of lymphatic disorders. And we do have in Los Angeles area, in Cedars-Sinai Hospital, a plastic surgeon who is concerned about treating lipedema patients surgically. USC has fantastic center in physical therapy and occupational therapy. And it was also the plastic surgeon, Dr. Ketan Patel, is also doing lymphatic surgeries and also lipedema surgeries. So we are starting to have different centers, but it's not specific center like we have here in Santa Monica, where we diagnose, and if clinically not sure, we can do testing or refer patients for lymphoscintigraphy testing, which is nuclear medicine testing. And in our center, we are doing ultrasound study, so we can confirm objectively what diagnostic approach we will have for these patients and so on. So I think, again, we do not have too many of centers, but they are starting. They are starting to have more physical therapists who are knowledgeable about lymphatic disorders, and there are a lot of massage therapists, and media is an excellent source for lipedema group, and they communicate a patient to patient, and then they guide where to go, which surgeon or which doctor they should go to. But again, this is completely open field for new physicians to learn and establish new centers.
So you do have the all over a network.
There is definite, yes, there is a definite network, and just, yes,
working on lymphedema and lipedema.
Right, and lipedema is, according to Dr. Etelfoldi in Germany, she coined it the incident rate of lipedema in Germany, not globally, but in Germany, about 11% of female population. And that's a large number. And I think we have more than 11% lipedema patients, and we definitely need new specialty. And perhaps with this wonderful podcast, we can give an idea to medical field to start thinking about residency aiming towards the lipedema or lymphedema or lymphatic disorders, residency and or fellowship.
Yeah, certainly I think a fellowship would be a fantastic addition for many physicians from various backgrounds. At completing their training, it would be, a fantastic thing. And I have to tell you, some ideas are coming to my mind as we have the beautiful technology of video here in our vodcast. That's called a vodcast, video podcast. in future shows, we'll have to be sure to bring some images to share on the screen, because the classic sort of pathognomonic body habitus and something and so forth is something that physicians and patients alike need to see, and then it's very identifiable. And Dr. Iker gave a beautiful description in words earlier, and I'll ask her to do that again when she described this 60-year-old patient she saw today with the cuffing and the sparing of the feet and all of the telltale signs. So to help people to make the diagnosis, but also when you talk about a number, let's say like 11% of German females having lipedema, you have to keep in mind that that's over a spectrum of the various stages of lipedema. Not everyone is presenting as the severe imagery of the extreme stages that we may have in mind. There are younger patients and less affected patients, et cetera, who may be at much earlier stage, and those diagnoses are even far more easy to miss at the milder stages of disease. Wouldn't you agree, Dr. Iker?
That's absolutely correct. And thank you, Dr. Chuback, for bringing this point on. And I am very concerned, and it is out of my subspecialty, a little specialty where I want to diagnose the children with lipedema. And frequently when the mothers are coming with the daughters, not only I do clinical evaluation on the mother as well as daughter, but I do ultrasound on both, and it will be in my next presentation of description of lipedema of different stages and different age groups. And my youngest one was 4 years old. And on the ultrasound study, you can see the changes in subcutaneous tissue. But what I want to point out that in our lymphedema center, and I have been here for close to 30 years, when I hire a help, I am looking always for a pre-medical or medical student. And I am happy to say that out of the lymphedema center, we already have few bona fide physicians, and one just finished, and she is now a specialist in wound care. And so she is so fully knowledgeable, Dr. Jeannie Franco. She is very knowledgeable about not only wound care, but how to treat and diagnose lymphedema and lipedema. And also a nurse practitioner school from north of California is sending me students, and they are spending sort of fellowship with me, and they are learning about this disorder. And not only we see lipedema, lymphedema, but all different kinds of disorders and different pathologies, but we are spreading the knowledge of the lymphatic problems into our new generation, and they are passing it on.
And I'm going to jump in with another thought that you just provoked. I'm going to give sort of a sneak peek of the future, something that we're hopeful will happen when you talk about Dr. Iker and Dr. Gloviczki and Dr. Melin, who will be with us in the future, and others, guests that we'll have, this kind of super team of experts in this very little known but very large area of medicine. We're hoping at some point to create some seminar series with even hands-on therapy where physicians can come for training and further exposure to these patients and how to make the diagnosis, the ultrasonographic piece of diagnosis and interpretation, hands-on therapy, manual lymphatic drainage, wrapping techniques, et cetera, a workshop of sorts. And that's one of our dreams. That's one of the dreams of the LymphCast cast, to make that a reality, because as we have this discussion, which frankly, I think is far better than I could have ever imagined. And I thought it would be a great discussion, but we're just bringing to light for ourselves, if for nobody else, what a great need there is for greater education so that we can help these people.
Vein Formula 1000 and Lymphatic Formula 1000 from Vita Support MD are backed by science and sold in doctors' offices. If you're a physician who may be interested in prescribing or selling these excellent nutraceuticals, please call 862-246-7877 to speak to a representative today.
Let me ask a couple of follow-up questions, and it doesn't matter which of the three of you wants to take it or take both. We've mentioned women a few times. We've mentioned their daughters having it. So is that, if the mother does have this, is that something you probably, in your mind, at least want to look out for or test the daughter fairly early on? Maybe Dr. Iker take that one, because you had mentioned that the 4-year-old came in, you diagnosed her. Is that something in general you try to keep an eye on? Like, okay, the mother has it, the daughter might get it too?
First of all, when we talk about lipedema, it is a genetic disability, genetic condition, and it usually involves female population.
Okay.
And in my practice, I only saw 2 men with lipedema, but they also had additional medical problem and hormonal disturbance. So when you have a patient with lipedema, when I see patients for clinical assessment initially, I always ask, who has your body shape? Is it your grandmother or your mother? And then, do you have any daughters? Okay. And if they do, then, and if they want to bring the daughters in, I am happy to evaluate them and examine them and do ultrasound. And then we take it from there. And there will be a wonderful lecture by USC on June 25th in Santa Monica, and they will have big section on lymphatic problems as well as lipedema. So anybody who is interested to attend, that will be a great start on learning about lipedema.
What about if a father has it? I know you said they usually come with other issues too, but is that a sign his son might have it, or at least something to look out for, or not necessarily as much as with women?
Paul, this is very incredible question that you had. Father can be the carrier.
Okay.
But the son doesn't get that. However, if the father's family passed the gene on the father, then father's daughter may have it.
Oh, okay.
Or son may be the carrier for the daughter.
Okay.
Now, I wanted to add, because they are talking about the genetic component, it makes me think about the venous disease, actually. And we had in France one absolutely amazing study done by the famous specialist in venous disease, Dr. Cornu-Tenard, who asked in one moment to test the genetic component of varicose veins. So he asked his patients to bring the kids, and was following with ultrasound the kids, and found that actually, you know, that there is a very strict correlation to from mother and father for having kids with varicose veins. So, and the development actually of these varicose veins, you can follow like almost linear following on the development of a venous reflux. So the wrong direction of the blood, instead of going up to the heart, goes down the legs. And this was absolutely wonderful demonstration how the venous disease develops slowly with the very strong genetic component.
I just want to point out that in terms of lipedema, the expression, the clinical expression is seen in women, not in male population, but the male can be carrier of the gene.
Okay, excellent. Let me turn it back to you, Dr. Chuback. Take it away. Your thoughts. You've been taking some notes, so take it from there.
Oh, I've been taking a tremendous number of notes, and I'm learning a lot, and I'm coming up with lots of great questions. You know, I thought that this observation from Dr. Iker about the gymnasts is fascinating. And I have to admit, I have made that same observation myself and have wondered a bit about the body habitus of many gymnasts, because it is unique and it seems quite reproducible amongst elite level athletes. And Dr. Iker mentioned about loose connective tissue disorder and the hypermobility of the knee, hyperextension of the knee in the standing position, etc. And I'm sure we're going to get into other subjects like, for example, Ehlers-Danlos syndrome. Dr. Iker, can you mention anything about that just briefly, if there's any such connection between these problems?
Well, I don't think that we have enough study to demonstrate the absolute correlation, but I think there is definite cross-DNA bridging between lipedema and hypermobility of loose connective tissue expression and Ehlers-Danlos syndrome. Ehlers-Danlos syndrome, I have not seen combined with lipedema, but they do have great hypermobility and loose skin, loose connective tissue to great extent. And so I think that there is, again, we are starting to now study about the DNA of lipedema. And I don't think that there is just one single DNA component. I think there are variation of different DNA elements with upregulation and downregulation. And according to that, we can see different expression, because even though we have different types of lipedema, not one lipedema is exactly the same as different lipedema in terms of shape and clinical presentation. And in Ehlers-Danlos syndrome, I have not seen combination of hypermobility, loose skin, and lipedema.
And Dr. Gloviczki, the question I had for you and for Dr. Iker, but because you touched on it, as far as I know, there is no specific genetic sequence or gene associated with familial venous insufficiency. And if there is, you can correct me. And the same question for Dr. Iker regarding lipedema. As far as I know, there are no specific genes or gene sequences described right now that we can test for. Is that correct?
So I will have to check honestly, because last time I was involved in the reflection about it, there was a very large genetic study that was starting. And I didn't had any update, but this is something maybe we should look for, because a lot of researchers were working on it. So logically, we should have some findings.
Fantastic.
A quick question for either Dr. Chuback, Dr. Iker. You both mentioned you've noticed this going on with gymnasts. Is there a reason they're particularly susceptible to this? And if so, what is it, or what's the reason? But are other athletes prone to this as well because of what they do during their sport?
I just have to point out that this is merely my observation, because gymnasts are very flexible.
Okay.
And when you think of the training in gymnastics, you have to really endure and force the hypermobility on normal subjects. But these gymnasts who already have predisposition of the hypermobility from the DNA component from their ancestors, they have hypermobility much greater and do it with ease than as opposed to someone who has to work much, much harder. And so along with that, you can see already a different shape of the lower extremity on little girls. The legs are a little bit fuller. And usually when you see lipedema patients also in children, from the point of view when they are standing up straight, the anterior thigh is little protruding, little bulging, and the legs are very firm, and not firm, but they are touching, they are straight down. And when you have a normal controlled subject, they may have a little bit gap between the legs, and so there is a subtle difference when you see already in the shape of lower extremity. Way back when I saw on YouTube this little gymnast, and her mother was guiding her to perform, and the kid was maybe 3-4 years old. And when I was looking at her, I thought, wow, how easily she could bend and do a front walk over. And then I looked at the mother and I said, oh no, she is lipedema. Mama is lipedema. And so I can see it in the little one too. And so it is important to start early and tell them about the diet, about nutrition, about what type of activities they should do, and not to overdo in terms of the hypermobility exertion.
And I would just jump in there to say, Paul, this is another area we want to be very clear. We're certainly not implying that all gymnasts or world-class gymnasts have lipedema. Right. These are observations, clinical observations on the morphology of the human body when you're looking from a clinical point of view. But it has to be recognized also that some of these findings are most likely simply the byproduct of the training that they do. Enlarged gluteal muscles, enlarged quadriceps, biceps, femoris, gastrocnemius from the strength training that they do, the tremendous power that they have in their legs. So again, it can be an area where what I was talking about early in the program, where there's overlap in clinical presentation and situations. So we don't want to sort of make any gymnasts or their parents anxious or nervous that they may have this tendency. But these are clinical observations that we're sharing as food for thought. Let's put it that way.
Yeah, makes perfect sense.
I totally agree, and I just have to point out it's not only gymnasts. My daughter is part of National Children's Choir. And when I see these beautiful girls lined up, ready to perform, I hate to say I'm observing their legs. And then I go like, okay, here it is. And so it's not only gymnastics. I think maybe in the future, it should be perhaps our goal to have clinical assessment of young girls in a school and to see if they have potential lipedema, and then guide the parents with what should be the treatment.
Excellent information. And again, as the only non-medical professional here, I can tell you I just learned a tremendous amount that I didn't know before. And I know other non-professionals will as well as the professionals in your field. Great information from the three of you. It's going to bring to the end LymphCast episode number 2. And let's thank our panel before we depart from Scottsdale, Arizona, Dr. Monika Gloviczki. Thank you, Dr. Gloviczki. We'll see you next time for episode 3.
Thank you very much. It was good to be with you, and see you next time.
Excellent, and excellent information today, too. From Santa Monica, California, Dr. Emily Iker. Thank you, Dr. Iker, for everything today. We'll see you next time as well.
Thank you very much, and I'm looking forward for the next session, and this was a wonderful session.
All right, excellent. And Dr. John Chuback, physician surgeon from New Jersey. Thank you, sir. Thank you for putting all this together, and we will see you next time for episode 3 as well.
Thanks, Paul. I just want to finish by saying, as I predicted early on, not only are we teaching, but I can speak for myself when I say that I'm also learning. We're always students, and every discussion, I think, leads to more knowledge, more questions. And one of the things that I really look forward to in the future is having Dr. Iker share with us, hopefully on screen, some of her ultrasound images of typical lipedema and the findings, because that will be a real education for me and something that I'll enjoy, incorporating into my own practice once I have the knowledge to do so. It's a fascinating subject, and so many great things to come. So many great things to come, and great guests as well.
All right, well, let's plan to do that, and that brings to a close for today, LymphCast episode number 2.